Paul Kalanithi died before he finished writing the memoir, so in some ways it's unfinished, but his wife Lucy sort of provided readers with a conclusion by writing a short afterword to kind of summarize the book as a whole. So these are her words. This book carries the urgency of racing against time, of having important things to say. Paul confronted death, examined it, wrestled with it, accepted it, as a physician and a patient. He wanted to help people understand death and face their morality. Lucy then goes on to summarize Paul's intentions by referencing an email conversation he'd had with a friend. So these are Paul's words now. I want to help others by allowing them to get into these shoes, walk a bit. That's what I'm aiming for, I think. Not the sensationalism of dying, and not exhortations to gather rosebuds, but simply, here's what lies up ahead on the road. Lucy ends by saying, of course, he did more than just describe the terrain. He traversed it bravely.
The quote you see is an example of how Paul describes the terrain, honestly, openly, and candidly. It's part of what's so unique about this book. Throughout the entire thing, he is open and honest about death, which is very much not the norm. Maybe experiencing death looming over you contributes to the willingness to have a discussion about it, but for the most part, American culture, and physicians especially, are extremely death avoidant, as Lucy points out in her afterword. A lot of research has been done to try and pinpoint exactly why this is the case. And while the literature does vary, some common themes that kept coming up were an exaggerated perception about the power of medicine and medical education. With regards to medical power, after 4 years of medical school, physicians train an extra 3 to 10 years on average in their field of choice in order to investigate, diagnose, cure, and most importantly, prolong the lives of their patients. Thus, social scientists have found that physicians oftentimes equate looming death or patient decline as their own personal failure. With regard to medical education, physicians are uncomfortable about the topic of death because they don't really discuss it much in medical school, as a medical school has a much more empirical focus. It chooses to place more emphasis on teaching students biochemical pathways and anatomy, rather than having conversations about the more subjective practices of medicine. Medical students spend maybe a month out of their 4 years of medical school discussing such topics, and as they are usually in elective courses, not all students take them. As a result, when medical students make the transition from student to physician and caregiver, they carry with them the sense of unfamiliarity and discomfort with subjective topics such as death. This is unfortunate because death and dealing with death is such a big part of the medical profession. The bottom line is that death is unknown terrain, and that contributes to a topic complexity that leads to a reluctance in discussing it. With regards to what we've gone over in class, this fits pretty well with the theology discussion we had last week with Dr. Virkler. Dr. Virkler introduced us to the subjectivity surrounding the basis of morality, which got me thinking that maybe another contributing factor to the U.S. and physicians' death-avoidant nature is the fact that death is one of those topics, much like religion and God and theology, that is extremely subjective, in that no one meta-narrative can sort the plurality of viewpoints surrounding it. Nevertheless, the death-avoidant culture that we see in doctors only works in their detriments and their patients' detriments. Something to leave you with. Imagine two identical patients, patient A and patient B. Both have terminal cancer at stage 4 and have tried multiple rounds of unsuccessful chemotherapy. Both are ready to accept their diagnoses and just want to go home and die peacefully. However, patient A's doctor has just found a clinical trial that might add a few months onto patient A's life. Patient A is ready to accept their diagnosis, but as their doctor keeps pushing, eventually agrees to enroll in the trial. Patient B's doctor has also found the same clinical trial, but instead of pushing it on patient B, this doctor gives them the facts about the trial and suggests they enroll. Patient B explains that they are ready to go home, and patient B's doctor doesn't push, simply agrees. One doctor in this scenario fits in line with the death-avoidant nature we've discussed, while the other one seems more accepting. Which patient do you think fared better in the end?
A week after the biopsy, Alexis, the nurse practitioner, called. There was no new targetable mutations, so chemotherapy was the only option, and it was being set up for Monday. I asked about the specific agents and was told I'd have to call Emma. She was en route to Lake Tahoe with her kids, but she'd give me a call over the weekend. The next day, a Saturday, Emma called. I asked her what she thought about chemotherapy agents.
Well, do you have specific thoughts?
I guess the main question is whether to include Avastin. I know the data is mixed and that it adds potential side effects, and some cancer centers are turning away from it. In my mind, though, since there are a lot of studies supporting its use, I'd lean towards including it. We can discontinue it if I have a bad reaction to it, if that seems sensible to you.
Yeah, that sounds about right. Insurance companies also make it hard to add it later, so there's another reason to use it up front.
Thanks for calling. I'll let you get back to enjoying the lake.
Okay, but there's one thing. I'm totally happy for us to make your medical plan together. Obviously, you're a doctor, you know what you're talking about, and it's your life. But if you ever want me to just be the doctor, I'm happy to do that too.
I had never considered that I could release myself from the responsibility of my own medical care. I just assumed that all patients became experts of their own diseases. I remembered how, as a green medical student, knowing nothing, I would often end up asking patients to explain their own diseases and treatments to me, their blue toes and pink pills. But as a doctor, I never expected patients to make their decisions alone. I bore responsibility for the patient, and I realized I was trying to do the same thing now. My doctor self remaining responsible for my patient self. Maybe I'd been cursed as a Greek god, but abdicating control seemed irresponsible, if not impossible. So we can use the scene between Paul and his oncologist Emma as a case study, and in a way to evaluate patient autonomy in the relationship between the doctor and the patient. So it should be noted that at the beginning of the scene, it's revealed that Emma has already made the decision to move Paul into stage 2 of his treatment plan. So Paul's already been through stage 1 of his treatment plan. It wasn't really taxing on him, but stage 2 is chemotherapy. And chemotherapy is pretty taxing on the patient. It can take a lot out of the body. And she only calls him to ask if he has any specific concerns, not whether or not Paul is okay with moving into stage 2 of chemotherapy, just whether or not he has any concerns about the treatment. So Emma continually makes the assumption that Paul would rather get better and live a good life, and live a goal-fulfilling life, go back to his work as a neurosurgeon, rather than ask him about the possibilities of end-of-life care. And this is exhibited through her continual refusal to tell Paul his statistics about his survival rate. She blatantly refuses throughout the book to give him this number and says, he can look it up himself, but that's on his own time. So Emma also recognizes Paul's autonomy in the decision-making process by listening to his concerns. She validates his fears, and he listens to his opinion on his treatment plan, but it's unclear whether or not this is because Paul does have that status as a physician, as a doctor. So we can't assume that she would do this in every doctor-patient relationship that she has, especially because she tells Paul, as a doctor himself, that it's okay to just let her be the doctor. And Paul's response to this is to state that he hadn't even considered releasing himself from his own responsibility. He's taken on the burden as the patient to make his own decisions. And he also states that he's used to his own patients being experts of their disease and usually asks them to explain their issues to him. So we can use this to assume that perhaps Paul appreciates patient autonomy and the idea of the patient as a decision maker. So in contrast, Emma shows an appreciation for less patient autonomy. She prefers the doctor as, the decision maker, the person who takes on the burden of choice in this relationship. And in class, in our readings, we talk about how there are differences among physicians, between regions, and within patients about who should ultimately be the decision maker, who should have autonomy in this relationship. So we talked about in France, there's actually a preference for the doctor to be the decision maker. They want that burden to be on the doctor as the technical expert. And in America, there's an emphasis on the patient as the decision maker because we value autonomy in decision-making processes.
During lucid moments, I was acutely aware that with this many voices, chaos results. In medicine, this is known as the WICOS problem. Who is the captain of the ship? The nephrologists disagreed with the ICU doctors, who disagreed with the endocrinologists, who disagreed with the oncologists, who disagreed with the gastroenterologists. I felt the responsibility of my care. During bouts of consciousness, I typed out the sequential details of my current illness, and with Lucy's help, tried to corral all the doctors to keep the facts and interpretation straight. I began losing track of events in time. I requested that these plans be explained to me, but sentences would become slippery. Voices would dampen and muffle, and darkness would descend in the midst of doctor speeches as I wobbled in and out of coherence. I desperately wished Emma were there, in charge. Suddenly, she appeared. You're back already?
You've been in the ICU for over a week, but don't worry, you're getting better. Most of your labs have normalized, you'll be out of here soon.
You know how you offered to be just the doctor and I could just be the patient? I think that's maybe a good idea. I've been reading science and literature trying to figure out the right perspective, but I haven't found it.
I'm not sure that's something you can find just by reading about it.
Emma was now the captain of the ship.
The issue of patient autonomy extends far beyond simply asking who should get to decide. One of the issues that Dr. Kalanithi describes during his trials at medical school are his issues with not being sure that he was the right person to make big decisions. When he was on call during his residency, one of the nurses told him that it was a judgment call whether or not to give a woman a C-section or a natural birth. In response to this, he says, "What a call to make. In my life, had I ever made a decision harder than choosing between a French dip and a Reuben? How could I ever learn to make and live with such judgment calls? I still have a lot of practical medicine to learn, but would knowledge alone be enough, with life and death hanging in the balance? Surely intelligence wasn't enough. Moral clarity was what was needed as well." So Dr. Kalanithi in this scene is describing how basically he's still human, that he alone doesn't feel that he is should be allowed to make these major decisions for patients. And it really reminds you that all doctors are just humans. That's really what they are. And they are forced to make these judgment calls on a day-to-day basis. And he is even saying that moral clarity is what would allow him to make these decisions. But moral clarity isn't something that can be taught in schools. Moral clarity isn't something that is innate. And I think Kalanithi has a very unique perspective because of his studies in literature and his passion for human life and understanding its purpose and understanding death. So his unique passions are what make him able to be a successful doctor and to make compassionate and correct decisions, while many doctors probably don't possess this quality. Another issue that Kalanithi describes during his time at medical school is the sort of dehumanization that occurs through the repetition of surgeries and cadaver dissections and patient protocol that occurs, and how it really desensitizes you to the importance of what you're doing. After his first cadaver dissection, Kalanithi is overwhelmed by the fact that he was not overwhelmed, quite frankly. And he says that cadaver dissection epitomizes for many the transformation of the somber, respectful medical student into the callous, arrogant doctor. This statement really illuminates the fact that medical school hardens doctors to a point where they might often not be making the decision that's best for the patient, and perhaps they're making the decision that's best for them, whether it's because they want to perform research or because they know that they're more skilled in a certain area. And I guess it points to the arrogance of doctors and really calls into question why we do treat them as the know-all figures who we can go to for anything and just not ever question their opinions. This brings up the sociological theory of the sick role and how you have certain expectations of you that are removed once you're sick, but you also have certain responsibilities as someone who is sick. And one of those responsibilities is that you are supposed to want treatment and that you are supposed to seek treatment. And it says
nothing about how you should make sure you're getting the right treatment or you should make sure you're doing what is right for you. The theory assumes that it's necessary to seek medical care in order to do what's right for you, and that reinforces the idea that doctors are possessors of truth and that we should take what they say at face value and take it as fact, rather than thinking that they are still humans and that they still make mistakes and that perhaps they don't have our best interests in mind at all times.